I'll be discussing the rationale and selection of focal therapy. I think that's really important as we begin this focal therapy session. Why does focal therapy make sense, right? We're in 2023. Focal therapy did not exist 15, 20 years for prostate cancer, but now I believe it's a prime time for focal therapy in US. These are my disclosures. Some of them are relevant to this talk, but majority of them are not. So we'll start the definition of focal therapy, and there are several definitions. Everybody comes up with their own definition of focal therapy, but one definition I'm listing here is from a consensus statement from experts who met in Kyoto several years ago and came up with a definition which would work well. And why do I think focal therapy is in prime time, and who will be the ideal candidates for focal therapy? So I believe this definition for focal therapy explains what focal therapy is. It is a guided ablation of an image-defined and biopsy-confirmed lesion. So both those things are really vital here. I think if you can see your target, you can destroy it well, and then you can review your efficacy well if the target disappears. So it's important to do focal therapy with a margin of a normal tissue around it. So this definition encompasses all those three factors. What's the objective of offering focal therapy? To eradicate significant cancer. It's still a cancer treatment, more cancer control than cancer cure, but we have to still ablate all significant cancer. And secondly, preserving genitourinary function. We know that with focal therapy, we are compromising oncological outcome to a certain degree compared to whole gland treatments. So what are we getting in return? We're getting better genitourinary function when we offer focal therapy to our patients. Why? These are the three reasons I believe focal therapy is getting more and more popular in the US. And I'm going to elaborate on those three reasons in the next few slides. Firstly, there are shortcomings in the treatment strategy. We have been either treating patients very aggressively, taking the entire prostate out, or radiating the entire prostate, or we are telling them you don't need any treatment. There's never been a middle ground in so many years. Over the last 15, 20 years, we understand the biology of prostate cancer better. In 1990s, we were treating Gleason 6 prostate cancers because we were thinking we're impacting cancer cure in that patient population, and we should not be treating higher risk disease. Gleason 6 is where you can create the most impact, but now we know that's not true. Prostate cancer has a long natural history, and we understand the origins of metastatic disease better. And finally, and this is probably the most important point, and that's why our conference started with this, prostate imaging. Prostate cancer was an invisible cancer which we detected by just randomly putting 12 biopsy needle cores in the prostate. We did not know the exact location of the cancer. We were not even certain about exact risk stratification, and we were treating these patients. But prostate MRI changed everything. It revolutionized how we manage prostate cancer and opened the doors to focal therapy for prostate cancer. So this is the first point, right? Radical surgery. We have ran 3 clinical trials, and Dr. Hamdi will be here tomorrow talking about PROTECT trial, which is the most recent one. None of these trials demonstrated any survival advantage of radical surgery, which is prostatectomy, over not doing anything for these patients. Now, as a surgeon, I don't believe that there's no advantage of prostatectomy. Prostatectomy has its own role, but it's probably not a treatment for all comers with prostate cancer. One thing we know for certain is, yes, it did not prolong survival, but it definitely caused side effects. Prostatectomies are known to cause incontinence and impotence, and which are permanent in a lot of patients. On the other hand, especially in Western Hemisphere, it's not feasible to put every single prostate cancer patient through active surveillance, right? This is a very carefully selected cohort of men in Europe who chose active surveillance. And within 5 years, 44% of the men dropped out. And there were several reasons. Some of them progressed. They had more aggressive disease on the biopsies, but a lot of them just got tired. They don't want more PSAs and more biopsies. Some of them got so anxious, they demanded treatment. So doing this for all comers for prostate cancer is just not feasible and probably not the best approach either. And that's why the middle ground of focal therapy is important. But there are criticisms of focal therapy. We're talking about a disease which is multifocal in 60 to 80% of the cases. So if the disease is multifocal, does focal therapy make sense? And secondly, we discussed in the previous session, prostate MRI is great and has great sensitivity for large tumors, but it does miss small amount of clinically significant cancer. So in this situation, is focal therapy ideal? And that's why the second point comes into picture. Our understanding of biology of prostate cancer has gotten better. And there's a hypothesis that there's the largest lesion of the prostate cancer called index lesion is the one which harbors the most aggressive disease and is prognostic and determines the pathological stage and oncological outcomes of these patients. And usually, if we can identify this large index lesion and we can target it in a guided fashion, then potentially we can achieve an oncological outcome comparable to whole gland treatments. There is evidence of this theory from work done by Dr. Stamey et al. From Stanford. They looked at 222 prostatectomy patients and looked at their whole gland specimens and defined the largest lesion, index lesion as the largest lesion, and they identified that the total cancer volume in a prostate correlates with the volume of the largest lesion. In their cohort, they actually found that multifocal patients did not do worse than unifocal patients. It's the cancer volume in that biggest tumor and the amount of pattern 4 and 5 in the biggest tumor, which were determinants of prognosis, not the secondary tiny tumors. There are several other studies, especially in the current era from UCL and Imperial College, proving the same point, that secondary lesions are not as clinically relevant as we used to believe in the past. This study from my partners at UChicago further supports that theory. This study looked at the somatic mutations between low risk, high risk, and metastatic prostate cancer focuses, and they identified that the low-risk tumors do not share any mutation with metastatic disease, but the high-risk tumor shares a lot of mutations with the metastatic disease. And they came up with the evolution plan for prostate cancer. Both low-grade and high-grade tumors arises independently from a common cell, but it's the high-grade tumor which gives rise to metastatic disease, not the low-grade tumor. Another study from Johns Hopkins also lends some evidence towards this theory. This study looked at 30 men who died of metastatic castrate-resistant prostate cancer, and they looked at 94 sites of prostate cancer. They determined that prostate cancer is monoclonal, which means a single cell in the prostate gave rise to all metastatic disease. And we have to give credit to Dr. Hashim Ahmed, who put all this information together in a nice review article 15 years ago, where he makes a case that prostate cancer has both high-grade focus and low-grade focus in the same prostate. However, it's the high-grade focus which changes into metastatic colon and gives rise to metastatic disease and leads to patient's death. So if we can identify this before it has a chance to spread to other parts of the body and destroy it, then do we really need to do a whole gland treatment for even multifocal disease? And that this power has been given to us preoperatively now by MRI. MRI has made this invisible cancer visible. We can see these tumors, we can target it with accuracy, and we can destroy them, making focal therapy a possibility and feasible in 2023. Going to the patient selection, we know there's some sense behind focal therapy, but how to identify these patients? And this is important to be really good, and probably the most important criteria which determines your success after focal therapy, proper patient selection, because that allows you to have adequate local ablation and decrease the risk of local recurrences and decrease the risk of failures. We know historically 12-core random biopsies have not been accurate in risk stratification. They understage prostate cancer, and they're definitely not accurate in locating the tumors well in the prostate. So we cannot rely on 12-core biopsies. And that's where, again, MRI has made it feasible for us to identify these tumors. This paper has already been shown several times, the JAMA paper from NCI, demonstrating that prostate MRI has much better accuracy in detecting clinically significant cancer. But we want to know about index lesion. How does prostate MRI does in terms of index lesion? This study from Germany looked at 120 prostatectomy specimens and reviewed their MRI fusion results with the whole gland prostatectomy specimens. And they found that index lesion was identified in 92% of the cases just by MRI alone. And when you combine MRI with a saturation biopsy, the detection was up 96%. So the way we biopsy these tumors now, we will have a great idea of which tumor to target if we do it properly. In addition, what MRI gives us is, okay, location of the tumor, tumor volume assessment, and very important is relationship. At lunch, we were talking about how even now, we don't use MRI to its complete extent. We don't use MRI for looking at the relations, the way we do with CT scan for kidney masses. We look at the CT scan, we want to find out if it's close to hilum, if it's close to vascular supply, if it's invading out of capsule. We still don't use MRI that often when we do prostatectomy. So I think with MRI, this is the biggest advantage, how MRI has made focal therapy possible, because you can actually see if your tumor is close to the urethra, tumor is close to the neurovascular bundles, tumor is close to sphincter, and you can avoid them to get optimal outcome for focal therapy. So you have identified the candidate, how to biopsy, and these recommendations are coming from a lot of consensus statements from experts in focal therapy. Unfortunately, their NCCN guidelines and EUA guidelines do not give us any criteria for patient selections, so that's the basis of my talk. So the consensus statement says that you have to get a target biopsy. It could be either a template mapping biopsy where we obtain a single core at every 5 millimeter of prostate tissue, and patients end up getting 45 to 60 cores. It has been shown to be 95% accurate in detecting prostate cancer and localizing prostate cancer. So that's one option. But more commonly used option is 12-core systematic biopsy with a target. In situations where your systematic core aligns really well with MRI findings, you can potentially offer focal therapy with just 12-core biopsy if you have a high-quality MRI and everything lines up properly. If there's no MRI, the only option is template mapping biopsies. What the experts recommend against is using only 12-core biopsy without MRI to offer focal therapy. So that definitely has not happened that commonly in the United States anymore, but in the past that used to happen. The other thing they recommend against is obtaining only target biopsy and not sampling the negative regions. And that's the recommendation, because we know from PROMISE trial, there are certain proportion of men who would have small clinically significant cancer only in the MR negative regions. So it's better to identify them preoperatively and weed them out versus deal with failures down the line. So I listed some criteria for ideal patient for somebody who's starting a focal therapy program, and these are some of the criteria I use when I started the focal therapy program. Of course, some of the borderline candidates which are not ideal can be offered focal therapy also, but I think starting up, these are probably the criteria. So if somebody follows, they'll have greater success in their outcomes. Life expectancy greater than 10 years for all prostate cancer patients, and destroying only the clinically significant disease, not chasing small Gleason 6s, probably is a better idea for focal therapy, and limiting it only to grade group 3 disease, would be more optimal to achieve efficacy. In terms of PSA, there's not much consensus. Some experts say 10, others say 15. I use 20 in my personal practice. I offer focal for all NCCN and intermediate risk prostate cancer patients. But the most important point, and this helps a lot in determining your success, is disease focality. Unifocal patients and unilateral patients tend to do better than multifocal patients. So early on in your experience, I think unifocal, unilateral, and anterior tumors, those should be better treated than the patients with multifocal disease. And of course, you have to review an MRI to make sure there's no high-risk features like seminal vesicle invasion, extensive extracapsular extension, and the tumor should be isolated from vital structures like urethral sphincter, neurovascular bundle, and rectum. The thumb rule is if you can destroy all clinically significant cancer with preservation of at least one neurovascular bundle and urethral sphincter, patients should be able to get focal therapy. I won't go into details of selection of energy modality because Dr. Thaneja is going to cover that in next talk. But selection of energy modality is dependent upon, again, MRI findings and prostate size. Some modalities are better for bigger tumors, others are not as good for bigger tumors. Some modalities are better for anterior tumors, other modalities are better for posterior tumor. But we'll cover that in one of the next talks. So to conclude, focal therapy is a personalized treatment option. You can dial it up, you can dial it down depending upon how much tumor you have to destroy and how aggressive the prostate cancer is. It definitely limits the harms of whole gland treatment and has the potential for durable local control and potential for retreatment. In terms of selection, most experts agree that a determination of focal therapy candidacy based on prostate MRI followed by MR-guided biopsy is the most optimal, and disease focality and disease risk are the two biggest factors which determine the success after focal therapy. And for somebody starting a focal therapy program, I believe unifocal or unilateral disease or anterior-only tumor with grade group 2 plus grade group 3 prostate cancers are ideal and will give an optimal result compared to starting with a multifocal tumor. And then I want to end this talk with this quote from a German physicist. I cannot say whether things will get better if we change, but I can say they must change if they are to get better, right? We need to change how we manage prostate cancer, and we cannot continue to do the same thing and expect results to get better by themselves. Thank you.